Good afternoon, everybody, and welcome to the UHN Clinical Epidemiology and Health Services Research Rounds. Today, we're delighted to have Douglas Cheung, who's going to be talking to us about the burden of prostate cancer through novel methods of early detection. This is a PhD transfer proposal. Doug is transferring from the master's degree program to the PhD program, which means there's a format we need to follow. It's a 20-minute presentation, followed by questions from anybody who's here. After the questioning is over, something which I guess I will decide, then the people who are faculty and IHN will stay behind and discuss the defense and recommendations. Okay, so Doug, I'm going to keep my eye on the time and tell you 20 minutes is up.
Perfect, thank you. So hi everyone, I'm Doug. I'm one of the senior urology residents and a student within IHPME. I'd like to acknowledge my supervisors, Dr. Khan and Dr. Finelli, as well as my committee members, Dr. Kulkarni and Dr. Mitsotakis, as well as my external reviewer here today, Dr. Ahmed Bayumi. Today, my proposal will be on discussing decreasing the burden of prostate cancer through novel methods of early detection. So a bit of background information to begin. In Canada, 1 in 9 men will be diagnosed with prostate cancer, and 1 in 29 will die from it. What this means is, over the past year, in 2019, there were 23,000 new cases of prostate cancer, and those represent 20% of the new cancer diagnoses in men. So for this large number of men, who gets screening and how? And although there's slight differences and nuances in the guideline recommendations, most agree that patients who are amenable for screening, or at least a discussion about screening, are aged 55 to 70, have a limited comorbidity, and have a life expectancy greater than 10 years. What happens next really forms kind of the crux of my thesis proposal, detection. So if your screen comes back positive, either your PSA blood test or your rectal exam, we've been using the same technique since it was discussed by Stamy et al. In 1989. What we do is we place a probe into the rectum and we do a systematic non-targeted biopsy. We map out the prostate into 12 zones and we sample each of those zones in order to detect cancer. As you can imagine, there's quite a lot of issues, problems with the traditional approach. For example, the first is detection. You can imagine that if your lesion just isn't sampled by one of the cores on the biopsy, or if it's quite small, it can easily be missed. Similarly, there's complications. These biopsies are not without morbidity, and even in the rare cases, mortality. So what that means is systematic biopsy will miss significant cancer in 1/3 to half of patients with a sensitivity of about 0.5 to 0.6. Furthermore, complications, so about a 2 to 4% risk of sepsis, might not be necessary in low-risk patients. That biopsy can be avoided altogether. This really highlights the issues around systematic biopsy, which are poor initial risk stratification of high and low-risk men, and poor targeting and yield of the biopsy itself. So there's a lot of room for improvement. And in the past few years, we've developed novel biomarker, which are urine and blood-based tests, as well as imaging strategies, which have revolutionized our approach to prostate cancer detection. So using biomarkers, these blood and urine-based tests, patients can be additionally risk stratified. So it acts as a node after they come in with an elevated screen, and only patients who are at high risk proceed on to biopsy. And low-risk patients can avoid the morbidity altogether. And there's a number of available biomarkers on the market now. Similarly, imaging offers another way and another approach. It improves the resolution of conventional ultrasound to risk stratify patients, but there's an additional benefit as well. You can identify a potential target, so a spot that shows up on imaging that can then be used for image-targeted biopsy. And there's a variety of imaging techniques as well, MRI, PSMA PET-CT, and high-definition ultrasound. So there's a lot of excitement for these strategies available worldwide. The European and American associations have released statements discussing and urging for the introduction of these strategies, but were tempered by limited evidence on their cost effectiveness. For example, it's thought that reflexive biomarker testing will cost about $500 to $1,000 for every patient, and imaging can cost upwards of $1,500 for every patient. There's also ongoing controversy about the benefits versus harms of the early detection of prostate cancer. So at this point, no decision analyses have really evaluated these strategies head-to-head against systematic biopsy in individual or combined approaches. Existing analyses are limited to single arms. They don't include staged or combination approaches. They exclude clinically important parameters, and some strategies haven't been studied at all. So our research question was to evaluate the potential clinical benefits and cost effectiveness of the imaging strategies and biomarker testing versus systematic biopsy as the standard of care for the primary detection, so in a biopsy-naive patient who has not had a biopsy before, of prostate cancer using decision analytic techniques. We've broken this down into 3 objectives. The first is a systematic review and meta-analysis of the diagnostic test accuracy, or DTA, of novel imaging and their associated image-guided biopsy strategies. We'll assess each imaging modality as 3 comparators and their associated strategy versus systematic biopsy. Framed within the PICO-PERD framework, we'll look at adult men at risk of prostate cancer based off of a elevated PSA or abnormal DRE. We'll examine each of the imaging-related strategies as comparator arms versus systematic biopsy. The gold standard reference test will be template mapping biopsy in the primary analysis. This is similar to systematic biopsy, except you take a much more extensive sampling, 18 to upwards of 30, 40 cores, in order to get a really good idea of what the baseline disease is in the prostate. And finally, we'll measure sensitivity and specificity for clinically significant prostate cancer for each strategy, as well as some other outcomes I'll go into. Our search strategy will follow the construct structures of clinical condition and the diagnostic test strategy of interest. This is in line with the Cochrane recommendations, which recommend that a 2-construct approach is taken because populations, settings, and exclusion criteria for diagnostic test accuracy studies are rarely included in the text, abstract text, and mesh headings. We'll review our search strategy with an information specialist, and we'll search the relevant electronic databases along with a manual reference search. We'll verify the strategy against landmark studies that have been identified a priori, and the full search strategy, data extraction, assessment for bias will be completed with 2 reviewers. We'll extract the usual study details. Focusing on outcomes, we'll look at sensitivity and specificity of clinically significant prostate cancer, or as calculated from the positive and negative cases respectively. We'll also look at the diagnostic accuracy for clinically insignificant cancer and for all prostate cancer combined. In line with the Cochrane recommendations, we'll report our analyses with a summary ROC plot for each imaging-based approach and with coupled forest plots for sensitivity and specificity and their 95% confidence intervals. We'll assess for the risk of bias and applicability using the QUADIS-2 tool by 2 independent reviewers. To address verification bias, studies that do not proceed onto pathology or don't get biopsy will be excluded. In our second aim, we aim to describe prostate cancer health state utilities using our in-house PORPUS database. So a bit of extra background on that front. So the Patient-Oriented Prostate Utility Scale, or PORPUS, was developed in 2000 and is a disease-specific psychometric and preference instrument across 10 domains. They cover pain, energy, support, communication, emotional well-being, and a variety of urinary, sexual, and bowel function. It's been previously validated in early and late-stage disease to assess health-related quality of life and in a wide range of treatment and care settings. In a systematic review using the MPRO tool, PORPUS was found to demonstrate excellent validity, responsiveness, and interpretability versus other prostate cancer tools. For our in-house database, we have 45,000 PORPUS measurements across 10,000 patients from a variety of pre- and post-treatment stages. making this one of the largest utility databases in the world. This was prospectively captured by a single individual largely over the course of a decade, with a couple years after where it was filled in by volunteers. We have some capture rates from the initial years, which, as you can see, are pretty good, with a 90% capture of patients who are coming in to clinic. We'll then take these PORPUS scores and map them onto health states. So these 15 health states have previously been defined and validated by our group in a published report, and they cover from diagnosis to death. So on the left, diagnosis and treatment strategies, moving on to surveillance, recurrence, and hormonal therapy, and eventually castration resistance and metastases. For each of these health states, the previously validated decision rules based off of clinical features, the duration and timing of therapy will be used to assign PORPUS scores to each state, to assess for the risk of misclassification bias, and to ensure that these rules will work within the PORPUS database. We'll do a random sampling of individuals and their PORPUS scores and times to be validated by chart review. The mean unadjusted estimates will then be pooled from all patients in each state and stratified by the treatment received. We'll look at the effect of demographics, patient and disease characteristics in multivariable OLS regression with separate models for early, recurrence, and advanced disease. To address repeated measures, we'll assess for clustering at the individual level. And these will further adjust our gross utility values for microsimulation in the upcoming model. So our third objective will really feed forward the results from the first two, as well as a literature search, to conduct a cost-effectiveness analysis for the primary detection of prostate cancer. We'll build a model looking at the strategies of imaging and associated image-guided biopsy, biomarker testing, and systematic biopsy as the standard of care. We'll incorporate the use of prostate cancer risk calculators, such as that from the prostate cancer prevention trial, to further triage patients to clinically important risk thresholds of disease prior to proceeding to diagnostic tests and biopsy. We'll also look at combinations of tests in the initial investigation, so right away you can get to, or in stage investigation with a representation to be assessed, but in exploratory analyses. And that will include combinations both where everyone receives the combination, as well as positive and negative reflexive testing. And what I mean by that is there's literature that shows that the use of these strategies in a positive reflexive test, so your first test was positive, then you get a second test, usually imaging to identify a specific lesion to target, as well as in the negative reflexive test setting, where you have an initial negative and you get a second negative to really rule out any significant cancer. The model will follow a healthcare payer perspective in line with THETA guidelines. A two-dimensional microsimulation and sampling Markov model will be completed with a 3-month cycle length with a lifetime horizon. We'll look at a discount rate of 1.5% in the reference case, and to adjust for a discrete time bias in Markov models, we'll use within cycle correction. The same previously described and validated health states that have been reported from Fire Group, again going from diagnosis in the top left corner down to death. The transitions go through treatments on the left-hand side, including active surveillance, watchful waiting, surgery, radiation, and hormonal therapy. Then patients move into a surveillance, recurrence, or hormonal therapy state, and eventually develop castration resistance and metastases. And all states can progress to death as well. Our base case will look at biopsy-naive men. This kind of goes back to the patients who would present following their screening, aged 55 to 70, with a low comorbidity index, what's been described usually in the literature is a Charlson between 0 to 2, and that's what will be modeled, as well as presenting with an elevated PSA with and without an abnormal DRE. We'll look at patient factors, and we'll take into account age, comorbidity status, PSA, DRE, and family history to be incorporated in microsimulation using trackers. We'll draw this in a hierarchical approach so that we're able to preserve some of the correlation For example, we'll draw comorbidity and PSA after age, so we'll get an age-specific distribution for those. As an additional analysis, we'll also sample the individual patient-level data that we have available, and that includes their patient characteristics and the correlation from the UHN prostate cancer database. Although that has a little bit more methodological rigor in that you're sampling patients and you know exactly their correlations, it may be a little bit more biased as we're a tertiary care referral population, so that will be used as the exploratory analysis as opposed to the primary. Not a comprehensive list of the data sources, but in brief, we'll feed forward the results from the first two aims, as well as costs that have been previously reported by our group across these 15 prostate cancer health states, measured as a function of 30 days from a healthcare payer perspective. We'll report a number of clinically important and summary outcomes. This will include the number of detected cases of clinically significant cancer, the time to diagnosis, the number of detected cases of insignificant cancer or overdiagnosis, biopsies avoided and complications as a result, cancer-specific mortality, and competing risk mortality. Summary outcomes will include the overall qualities gained, total costs, and an incremental cost-effectiveness ratio assessed across a variety of thresholds. In the primary analysis, we'll use probabilistic analysis with additional sensitivity, scenario, and structural analyses. Specifically, in some cases, model parameters may not be able to be obtained well directly from the literature as they represent inaccurate or biased estimates, and these are well suited for calibration. So the best example is actually something we've talked about a little earlier, or the observed diagnostic test accuracy that we're getting from these studies. And this is really a function of the true background baseline rate of cancer and how well these tests are able to diagnose the cases of prostate cancer. So we'll attempt to decompose this into the relevant parameters, and we'll perform latent hypercube sampling in order to calibrate these. We'll simultaneously calibrate the background cancer rates, as well as a proportion of those which are clinically significant, as well as diagnostic test accuracy, including the sensitivity to clinically significant cancers, insignificant cancers, and specificity. Our targets will then be the observed and the produced diagnostic test accuracy cases from our systematic review. We'll sample each parameter across a range of clinically plausible values, divided into 10 gradations to generate 10 to the 5 samples. We'll assess forgiveness of fit using equally weighted standardized Euclidean distance, and we'll select the top performing samples to be used in probabilistic analysis in the model. Finally, for validation of the model, we'll assess for face validity of the model and structure and outputs by members of the thesis committee who have extensive experience in uro-oncology and economic modeling. We'll assess for internal validity, comparing the predicted versus observed outputs of the incorporated studies, as well as the internal model logic and of generated results, and those of the sensitivity analyses. And finally, for external validity across studies that are not used in the analyses. And the best example there is the landmark PROMISE trial, which they only had imaging but did not proceed on to biopsy, which is why it wouldn't be used in the systematic review, as they did not have pathology. So returning to our objectives, we hope to produce 3 projects from this: the systematic review and meta-analysis for the diagnostic test accuracy of these imaging strategies, to describe robust health state utilities for prostate cancer using our in-house database, and to conduct a cost-effectiveness analysis for the primary detection of prostate cancer. I'd like to acknowledge the funding that I've received for this project thus far, as well as members of my thesis committee, including my supervisors, Dr. Kwan and Dr. Finelli, my other committee members, Dr. Kulkarni and Dr. Mitsukakis, as well as my external reviewer, Dr. Bayumi. Thank you.
So we'll take questions now, starting with comments.
Thank you. That very nice presentation. Congratulations on a well-presented thesis proposal. We'll start just with the systematic review and meta-analysis. Did you consider doing a network meta-analysis at all? Because you're going to have lots of studies that compare against probably a reference, but very few studies that compare the modalities to each other. How are you going to address that? And what are the challenges of network meta-analysis for a diagnostic test?
Yeah, I think that a network meta-analysis is certainly something that we would consider. As you know, like part of our study is we want to look at, we want to review studies that have essentially, we want to be able to compare these strategies directly against each other when they may not be compared directly in the primary study. In that case, particularly for template biopsy, as a reference standard, it lends itself well to assist to a network meta-analysis and would be something that we would consider. That said, the majority of studies may or may not necessarily reference against that. So in our other analyses, we will already be directly comparing, let's say, MRI versus systematic biopsy, and we're going to explore kind of a number of combinations of these strategies against each other. So kind of it does lend itself well to a network for versus template biopsy, but we'll also be able to assess the effect versus systematic biopsy through our stratified analyses.
So now we can move on to the utility chapter. I'm still not entirely clear about the role of the regression analysis. As I understand it, you're going to take your database and you're going to find men in that database who match the health states and then calculate their utilities. And then, so what does the regression add on top of that?
Yeah. So our hope was that when we are finally filtering through to the decision model, that we'd be able to adjust those overall mean utilities for patient-specific variables. So it allows us to be able to develop a regression to gain estimates for things like age for PSA and disease characteristics at baseline that we can then use to essentially get that extra granularity of how those utilities are adjusted in light of these other patient and disease features. The kind of benefit of that as well from the utility study itself is also not much is understood about how these different characteristics contribute to the health-related quality of life in prostate cancer patients, and particularly in advanced prostate cancer patients where the existing studies are just so small. They're only really on the order of 10 or 20 patients. So because we have such a rich database, we'll be able to get a much more comprehensive understanding of the health-related quality of life and the predictors of that within each state.
So you have 15 health states.
Yeah.
Are you running 15 regression, like you're doing a regression for each state to look at those other covariates and how they affect utility, or are you putting them all into a single model that somehow also incorporates health states?
Yeah. Essentially, we're going to build separate models for early, recurrent, and advanced disease. Our thought was conceptually there's likely an interaction between these different characteristics and disease stage. So it would be inappropriate to build a whole global model that just wouldn't be suitable to reflect the nature of these relationships. That said, to build a state-specific model and have 15 models also isn't very pragmatic and would be difficult to interpret. So we've tried to group them into 3 categories of early, recurrent, and advanced disease, and to build a model based off of each of those.
And then you mentioned in your written proposal that you're going to have lots of values close to 1 for some health states. And you talk about using beta regression for that as one way. Do you know any other ways that you might approach that?
Yeah, so in our reference case, we're going to use OLS regression, but because we have a lot of utility values that are close to 1, there are some studies that essentially debate the bias of these. So we'll compare it against theta regression. Another strategy would be to do it after log transformation to ensure that you don't have that issue as well. Or you can do kind of similar to a survival analysis where you start at 1. So there's multiple different strategies, and we would compare the estimates that are received as each of those regression models.
Yeah, there's some newer methods as well, but we'll talk about those later.
Okay.
Yep. And then maybe just one more question if I can.
Sure.
About the modeling.
Sure.
Particularly about the calibration. So, calibrating a microsimulation model can be challenging because the computational burden is high if you're because you really want second order estimates to get there. And you've proposed using Latin hypercube sampling for that, but that's not really a search algorithm. It's a pretty blunt way to do it. Did you consider using any algorithms that are more focused and that might be quicker than Latin hypercube sampling? And why or why not use other ways?
Yeah, so with Latin hypercube sampling, as you've mentioned, the risk is that we might not find necessarily a global minima because it's not necessarily a directed search algorithm. And the goal would be in the primary analysis to run multiple iterations of Latin hypercube sampling in order to get a good idea of what are probably the minima associated with that. Another approach would be to use Nelder-Mead. That's something that's been now built directly into native triage. So we would be able to perform a directed search as well to try and get estimates for those parameters. So kind of a combination of LHS and Nelder-Mead.
Are there other methods too?
Simulated annealing, and different types of grid search and stuff. But for directed, the ones I'm familiar with are Nelder-Mead and simulated annealing.
Okay, you can open it up to the whole audience now for questions. I have a question then.
Okay.
You gave some details around the systematic review and the analytic methods, and you mentioned plotting things on our C plane and then summary estimates. Can you talk a little more about how you're going to summarize, even if you don't do a network meta-analysis, just standard, for one of these imaging modalities, how you assess the diagnostic accuracy?
Sure. Let me just click through. So in terms of a more specific analytic methodology for the diagnostic tests, so we would use a random effects model as heterogeneity is generally presumed in diagnostic test accuracy studies. And to assess for sensitivity and specificity, we would make a joint modeling, hierarchical modeling approach to preserve the correlated nature. Specifically to your point about summary ROC curves, that would mostly be used to analyze additional different thresholds, and that's most relevant for MRI, where there's different PI-RADS thresholds, which is how MRI is reported in order to generate a cutoff for whether or not to proceed with for biopsy. Yep.
So why 2 months?
Sorry?
Why 2 months for cycle length?
Yeah. So I think a 3-month cycle length is the most clinically appropriate cycle length. It follows what we generally have for the follow-up of these prostate cancer patients. So it allows us to have something that's relatively reflective of real-world follow-up, as well as is granular enough to capture most of the effects that happen within prostate cancer. Yep.
A question regarding utility. So I'm not familiar with the measure for prostate cancer, but does it allow for negative utility values?
So the PORPUS scale does not. It's anchored at 0. So that's something that is a little beyond the scope of this project, but something that in the future would be interesting to look at.
Most utility scales allow for scores that are worse than that. Mm-hmm. So when you model them, you have to be careful because typically data regression is between 0 and 1. That doesn't allow for negative values.
Ask another question?
Sure.
So, there's still a debate in the literature about using community utilities versus patient utilities, and you say in your proposal that you'll do sensitivity analysis using some sort of community rating.
Mm-hmm.
But if your goal is to do a cost effectiveness analysis, what's the theoretical justification for using patient ratings for each group?
Yeah. So essentially, we've thought a lot about the patient versus community weights issue. As mentioned, economic evaluations tend to use community weights, but it's been shown, at least in prostate cancer, that patient weights may better capture the nuances of disease. There's studies that show that patients rate certain aspects higher, particularly with things like sexual function, where there's adaptation, there's response shift. So by using community weights only, they're going to undervalue benefits versus the side effects of treatment. The other aspect is patient-reported outcomes are increasingly becoming common and accepted by clinicians. So kind of in light of that, we'll try and model both within our model to get a more comprehensive look at health-related quality of life.
Do you think the patient weights should be the primary analysis?
I think that, tough question. I think they offer different unique pieces of the puzzle. Neither one necessarily would need to be the primary, but they offer different insight on how people might rate quality of life, and they offer very different perspectives. So I think it'd be useful to analyze both, and kind of, as we have it currently, it's more of a co-primary.
Oh.
Yeah.
So in diagnostic studies, oftentimes, they stop when they look, gold standard versus the new test. But oftentimes they also follow longer to see if there is effect on, treatment decisions, outcomes, costs. Like, I don't know in this particular case, but do you expect to find studies like that? And then are you going to use some of the information maybe in your model?
Sorry, I'm not quite
Oftentimes
sure.
they just look, compare gold standard, they say, this is diagnostic testing parameters, but they oftentimes also follow patients over time just to see if these decisions, have impact on treatment decisions, survival. Like, do you expect to see studies like that, or they just stop early? And then if you see, are you going to use some of the information?
Yeah. Commonly within prostate cancer, for the gold standards, we generally haven't used clinical diagnosis as the gold standard. Certainly in other diseases, they've looked at it, with receiving a clinical diagnosis within somewhere between 2 to 10 years. But within prostate cancer, at least, that hasn't been done so far, and would be kind of beyond what we're able to do for that.
This is really good. I'm trying to keep up to your slides and your explanations. You're doing a terrific job. I guess I wanted to ask, do you have, although many of these presentations are sort of geared towards you sort of defending what you want to do and getting questions and stuff, but would you say you have 1 or 2 questions of greatest uncertainty about what you propose to do that you might take the opportunity and ask people in the room how they might approach it? Sort of flip the table if you want and say, here's what I'm really uncertain about, and what would people do here? There's a venue for that, but if there is one, if there is one question that you think, I would like input, this is a good opportunity to get lots of smart people giving you that input. There may not be, but if there is, feel free.
Nothing immediately comes to mind.
No problem. Just wanted to make sure you had the opportunity.
Yeah. I guess if you wanted to suggest other calibration methods that you think might be better suited, Dr. Begumi, that would be very helpful. Kind of right now, we're probably leaning towards an LHS approach so that we get kind of from a pragmatic perspective, we're able to decrease the computational burden while getting a relatively good sampling. But if you had recommendations beyond that and elder need, that would be useful.
Alex related anything, but you have to go over the coding to be able to do it.
Fair enough. Dr. Cook?
You outlined a number of, or 15 health states, and that publication is 2018, but most of your utilities are from, I think, 2000 to 2010 or 2012. So some of those health states didn't exist or weren't really recognized back then because of the rapidly evolving nature of prostate cancer. So how are you going to slot utilities in to the newer health states if you may not have that kind of data?
Yeah. So the utility database right now, the latest measurements are from 2016. It gives us especially if you look at those later years, the majority of where the change has happened is in the advanced prostate cancer space with certain therapies that have moved earlier on into castration-sensitive and non-metastatic CR. So we would still have a rough idea of how those states would act based off of, we have about 40 patients and 300 observations for patients with ABI and ENSA, which really are the same treatments, but essentially apply to an earlier setting. That would give us probably, I think, the best approximation and would be, I think, the most feasible.
Yep. Following on this question from earlier, so what is the benefit of the regression modeling for you mentioned getting more granularity on the estimated utilities. So could you describe it a little bit more? Because one argument might be, well, you have this 15 health states, you've got the utility for being in a health state. That's what describes utility being in a health state. We really don't need to know what else. Other things can change someone's utility, but it's not a health state. It's something that could be something that's not part of the health state. So why is that important?
So essentially, as we're building the microsimulation in the essentially there's reasons from both the utility study perspective as well as the overall model perspective. From the model perspective, as we're building the microsimulation, it's more reflective of the inherent uncertainty that there is with regards to that health state, whether it's specifically just globally to that health state or with different characteristics.
Can you give a concrete example
characteristics
of how it might be important?
Like one huge one would be, for example, like comorbidities. Like a lot of these patients have other events that happen to them, and if you're able to assess how having a comorbidity changes your health-related quality of life, that's a meaningful difference. That would be kind of a within state difference that you would want to accurately represent.
So the PORPUS score you have from people filling out the PORPUS and then getting scored by the scoring algorithm.
Yeah.
Okay. So how would they be different for people with different comorbidities filling out with the same score? They're all going to have the same, but how many different comorbid conditions they have, they all get the same score, don't they?
So within the PORPUS score, where there's many other fields that are trying to capture these other disease characteristics, whether they're disease-specific, patient-level comorbid effects like comorbidities, demographic-level effects like income and age, and we won't be using all of them, but at least from a pragmatic sense, the ones that contribute most to prostate cancer, age, comorbidity, PSA, DRE, family history, those ones we're hoping to get some estimate from what's being recorded in the PORPUS database on their subsequent effect on how they approach their health-related quality of life.
Look at it this way. So if you're simulating, that answer that I'm not supposed to. I mean, what you're trying to do is simulate the progress of individuals throughout a trajectory, and people will create unique paths through these sets of health states. Over time, they will get older, and they will acquire comorbidity. What we will have if we don't adjust is mean utilities for those scores, conditional on the distribution of comorbidities and ages for the people who gave responses for that health state. that is not necessarily the distribution of age and comorbidity of individuals who will track through that system. So what we'd like to be able to do is have a model that will call age and comorbidity adjusted utility scores for that health state as individuals track through the model. Does that make sense? No.
Don't know.
Good start. Very good presentation. I have quick comments about I think one of your study, you're looking at whether or not MRI added MRI as the value the patients beyond the biopsies, the way they detection prostate cancer. And then you're doing the systematic review. I'm wondering, what if you do that chart review, then maybe get the more precise data on those patients who had the biopsy and MRI and see how much detections differ in the MRI and the biopsy. I'm wondering if you have some thoughts around and knowing that there might not a lot of studies who has reported the MRI-related outcomes in the literature.
Yeah.
So,
yeah, definitely we can look at what the local diagnostic accuracy is for these tests. But kind of at the end of the day, it's thinking about what the generalizability and applicability of our results will be. And we know that, I could do a chart review here at UHN, but it will be the tertiary care referral population. Our MRI readers, as well as performers of targeted biopsy, are excellent, but may not be representative of what's around Ontario or around Canada or worldwide. There's good studies that showed that even, for example, within Ontario, they looked at 3 sites and the performance of MRI, and the top site had 3 times better performance than the bottom site. So there's a lot of variability there, and just looking at a single site with chart review wouldn't really capture that.
If there are no more outstanding questions, I'm going to thank our speaker again. Thank you very much. If you are IHP faculty, please stay behind for discussion, and if you're not, out.